Thank you, Ashok. It's wonderful to be part of this great program that is chalked out by Gurva. My brief is to declutter stems, leaves, and cones. And I think these are very important tools in revision knee arthroplasty. And if you believe that you're going into war, you really need all that is there in the armamentarium that you have available. So it's a war that you're going in for, so you want to have everything available to you. I think bone loss is the biggest challenge in revision total knee arthroplasty. And even if you look at type 1 bone loss, or grade 1 bone loss here, even in this situation, ultimately the load transfer that's going to take place is dependent on the cement bone interface. And with this kind of bone at the level of the joint, you're still not very happy with the kind of cement bone interface you're going to have. And effectively, the load transfer, you would rely on the stems in such situations. And most of the times, these are the kind of stems that you rely on. We ream both femoral and tibial sides. We want to establish the endosteal bony contact with the stem, as you can see here on the tibial side and even on the femoral side. And then effectively, you are happy that reasonable bone transfer, load transfer will take place through the diaphysis. And the metaphyseal or even the joint level cement bone interface won't be stressed too much, and it will have a good longevity of that implant. So let's consider what are the options that are available with the stems. Now stems, most of the times in total knee arthroplasty that we use are smooth and polished. Very rarely this kind that I showed earlier. Very rarely you would have grid blasted, and most of the times grid blasted stems are used for arthrodesis nails like this. And these are the titanium stems that are aiming for bony on growth, and that is what. So the purpose here is quite different, and you don't have these kind of stems that are used in the total knee arthroplasty. So second thing is about the length of the stems. You can have short stubby stem like this that is going to be fully cemented both here, as you can see on the tibial and femoral side. You can have medium length as I've shown earlier, or you can have a very long stem that is again going to be engaging in the diaphysis of the bone. Now these stems could be fully cemented or just metaphyseal cementing. Now if you are using a medium stem length as you are seeing here, my personal choice is not to have the entire length cemented, for a simple reason that, as somebody said earlier, you have to think of the next surgery that potentially might be needed. And if you end up cementing the entire diaphysis with this kind of stems, then it's going to be a nightmare trying to take the cement out if you have to at any stage. So most of the times, my preference in these stems is just have metaphyseal cementing and have endosteal bony contact with uncemented portion of a smooth polished stem, as you are seeing here. So that is the metaphyseal cementing, that is my preference. But of course, there are situations where you need to fully cement. One is when you use a short stubby stem that has to be fully cemented. And there is another instance that I'll show you in a minute. And another option that we have with stems is whether you use a straight stem or an offset stem. We'll see that in a minute. Now you have a situation like this. It's a periprosthetic fracture, and when you come to reconstructing it, there is no metaphysis left at all. All you're left is tearing is diaphysis. And in these situations, you have to fully cement the stems in. And in fact, fully cement the stems in with a cement restrictor, and as you can see here, the cement restrictor on top, and this stem is entirely cemented in. And that's the only way you can get decent stability with this, and you can have a good outcome with this kind of situation. The next option is that whether you use a straight stem or an offset stem. Now, straight stems have a tendency of dictating the position of the prosthesis on the end of the bone. For example, as you can see here on the femoral side, the femoral component is lateralized. Now, offset stem, as you can see on the right hand side, is what is going to allow your prosthesis to be centralized on the bone in mediolateral plane. And because it can rotate 360 degrees, you can even have a better position anterior posteriorly as well. And the same situation is true on the tibial side as well. And you can decide this position using what is the optimum position during surgery while you are using the reamer. Now, another choice that is available with some implant manufacturers is having a split stem. And as you can see here, the split stem on the femoral side, you can have similar on the tibial side as well. Now, split stems actually give you a good endosteal contact and give you a good torsional stability as well. And because, here you can see the example of offset stem on the tibial side as well. Now, one point to note on the offset stems is that the shoulder, or where the offset stem engages with the tibial base plate, that point of contact depends on the height of the tibial base plate. And tibial, component actually, if it is too tall, this point of contact is going to be much below. And sometimes in small size tibia, that is a problem with the shoulder of this construct hitting the endosteal side, and that can have its own problems. So there are newer process designs where the tibial base plate is pretty short, and that actually the shoulder of this construct is actually goes high and into the wider region of the metaphysis. So that's quite useful using this kind of construct. Let's come to sleeves now. Now, sleeves are metaphyseal uncemented structures that have a scratch fit in the metaphyseal area, and they are used in combination with uncemented intramedullary stems, or sometimes without a stem as well. Now, these sleeves, especially the one that is seen here, is perhaps the most popular one. That's from Depew, and it has a porous coated sleeve area that is intended for bony ingrowth. As you can see, that almost is about 30-40% of the sleeve is having a porous coated area. I'm just going to show you one example of that. Here is a patient, again, had no metaphysis left here, only diaphysis left. And this femur is being broached to accept that sleeve. And this is at the end of the broach. And that is the component going in with the uncemented stem being put on. And that is a sleeve that is engaged here. And similarly on the tibial side. And as you can see here, these are the processes that were implanted. This is a Noyes hinge that was used. And the area of the porous coating is only about 30-40% of the entire sleeve. So it's only a small area of the bone that is engaging with the host bone, and that is the area where you are hoping for osseointegration, and that actually allows for load transfer down the metaphysis. Now, it's important to appreciate that whatever cement gets used, for example, here on the tibial side, there is some cement being used that is actually cosmetic, because this tibial base plate is actually going to have a more stipper inside the sleeve, and that is how the the tibial base plate engages or fixes into the sleeve. And this cement is for cosmetic purpose only, for a good looking X-ray. Otherwise, you could use you could use no cement there, and you would see a gap on the X-ray. Let's consider cones now. These are again metaphyseal filling structures. Now, there are two types that are available. One is structures that are aimed at bony integration on surface only. And second is, second type of cones is aimed as structural bone substitution. Now, these are the ones that are introduced by Stryker. These are triathlon titanium cone augments. They are made up of titanium, where you are expecting to have bony ingrowth onto the surface only. So these are not actually bone substitution, but aiming for like an uncemented implant having bony on growth and ingrowth on the surface only. Whereas the trabecular metal that was introduced by Zimmer is a femoral cone augment, and this actually is a bone substitution material. This is made up of tantalum, and this is excellent material that has open cell structure and high volumetric porosity of almost 80%. Low modulus of elasticity, so that is perfect to use with subchondral bone, and surface coefficient of friction is extremely high. And bony ingrowth is seen very well with the trabecular metal, and there are various kinds of shapes that are available. For example, here on the femoral side, you can see femoral cone. One example on the tibial side, big tibial defect on the medial side is the trial cone in place and actual tibial cone in place. Now, it's better to cover the outer side of this cone with cement, because these are quite irritant to the soft tissues. That is the post-operative X-ray and 5-year follow-up of the same patient. A difficult case with supracondylar non-union with arthritis. Again, it's like there's no only diaphysis remaining. So, cone has been used to reconstruct the distal femur, and a hinge has been placed on top. That is the post-operative X-ray of the same patient. And that's a 6-year follow-up of the same patient. You can see that bone was hypertrophied, whereas the cone is engaging, and that tells you that the load transfer is taking place very well. Now, there are various shapes options that are available with tibial cones as well. The problem sometimes is with the size of Indian bones that are available. Just one example of tibial cones being used, tibial that is collapsed completely. And these are intraoperative pictures showing a diaphyseal cone going in, and that is how it is fixed in place. And then inside this is the tibial component that was cemented inside, and that's how it was reconstructed. So tibial metaphyseal cones have to be considered as bone substitution options rather than implant components. And to summarize, I think these are all essential tools for revision arthroplasty. Each is going to serve a specific function, and one has to really understand the utility. And most of these revision TKs are going to need stems, so one can decide about the type of stem and the length of the stem that is required. And it's in addition to the stems is dependent on the amount of bone loss and the stability that is necessary. Thank you very much.